remember, traditional psychology says what's wrong with me or what's wrong with you. Trauma-informed psychology asks what happened to you. Culturally formed psychology asks what happened to your peoples. Yeah. And we have an abhorrent track history in terms of what we have done as a society to autistic and neurodivergent and neurologically different bodies. Liberation psychology asks, and what continues to happen to you and to your peoples? Yeah. And that's where we then have to take into account what is currently happening structurally and systemically. So here we have autistic traits versus autistic trauma. So the early recognition of someone's innate divergence can be the biggest preventative and protective factor from someone then experiencing autistic trauma. Yeah. To answer Fran's question. Yeah. And this is where I refer once again to a decolonized approach to secure attachment, a more expansive conceptualization of secure attachment that involves your identity. What happens to your nervous system template for attachment when the systems and structures of society do not give us messages of secure attachment, do not give us messages around welcoming you as you are fully into this world? And so to create spaces where we can feel safe enough to unmask, safe enough to be ourselves, safe enough to sit side by side with our clients, engage in parallel play, talk about our special interests with each other. Yeah. Be able to sit on the floor, rock our bodies, have our sensory needs be met within session. Yeah, it can be a shift for someone. It can be a shift for someone. Yeah. And so here, actually, I'm going to pause this here. So everything that I've said thus far around autism and neurodivergent affirming practices framed within a societal complex of ableism, patriarchy, white supremacy. I invite you to pull all that forward as it applies to ADHD and to consider what Janae Elizabeth says around the possibility of there's ADHD traits, or the actual reality, there's ADHD traits, and then there's ADHD trauma, where some of our inherent traits may be pathologized by society. And then when we self-regulate, when we stim, when we start to stim more incessantly, that can also then be further pathologized. And so in terms of diagnosis, there's a couple of buckets. There's the inattentive type, and then there's the interactive impulsive type. Having studied with Bessel for a while, Bessel's like meh when it comes to the ADHD diagnosis, because he is so in his trauma lane. And one of my early clinical supervisors said to me, Linda, you need to learn more about life than just trauma, right? Because you're going to see clients who have more than just trauma. And I'm so glad for this advice, because what I started to see was that once I started working with folks through their trauma, I actually started to see innate neurodiverse qualities beginning to emerge. Yeah. And in some cases, I would see some of their neurodiverse qualities actually begin to subside. And that's where the neurodiverse qualities that subsided were those were those that were related to the autistic trauma or to the ADHD trauma. Yeah. So this really upended what I learned in graduate school about assessment and diagnosis. And so this is where I want us all to hold an open frame, that getting to know your specific person who is in front of you so that you can actually begin to notice any shifts that arise. And I know that it's easy to want to label it as good or bad or better or worse, or, you know, this is getting better and that is getting worse. And to just keep an open frame around this. Yeah. Because there's so much that's emerging from first-person lived experiences of folks in the neurodiverse community who are doing parts work, who are doing their sensory profiles, who are engaging in brain spotting and EMDR and other trauma reprocessing modalities, engaging in the safe and sound protocol, and really telling us what it is that their nervous systems need in terms of trauma-driven care for the neurodiverse nervous system and psyche. Yeah. And so, okay, so diagnosis. Yeah. Diagnosis. Yeah. Yeah. And so I also love the work of Dr. Neff, and this isn't Dr. Kristen Neff, it's Dr. Neff, who's, I believe, a psychiatric nurse who is autistic and ADHD, who creates wonderful infographics. And the reason my brain loves infographics is I'm more of a visual learner. And it also helps that pattern finding part of my brain. I don't need to try to find the pattern. Someone else has already. Thank you, Lou. Dr. Megan Neff. Dr. Megan Neff has done the work of finding the patterns for me. And then that alleviates the part of my brain that is always on hyperdrive trying to find patterns. Yeah. And so let's see here. And this is where I just want to acknowledge it is really, really, really hard, because ADHD can look like PTSD and PTSD can look like ADHD. And yet to bring into the conversation ADHD traits versus ADHD trauma. And what I have found, actually, I'll leave the screen share up while I talk about this. What I have found is that the need to mask diminishes with an increase in social support, an increase in finding community, and with an increase in self-acceptance as a result of finding these external affirmation, yeah, of who I am and how I am. And doing the trauma work also means that my protectors can also begin to soften and let go. Like my protectors that have told me that I need to mask all the time because my ADHD or autistic traits aren't welcome into the world. Yeah. And this right here is then the ability to code switch intentionally. And code switching is a term that that I learned about as a person of the global majority, where when I go into white-bodied spaces, I walk and talk and behave, you know, in a more individualistic style and manner. And then when we're in more collectivistic spaces, there's that sense of being able to be more fully my Vietnamese self. Yeah. And so, and initially, and I'll just be honest with you, initially when I learned the word code switching, I actually went, huh? Because I didn't know how to be my full Vietnamese self, because masking in terms of being in a very white-bodied world has been the majority of my life experiences and how I've learned to survive. Yeah. And so I share this because you may also find this with some of your neurodivergent clients, like that unmasking may be like be like, huh, I can unmask. And yet when we do the trauma work around your one's protectors, whether you use the TIST model or the IFS model or dissociative tables or whatever ego state model that you use, you may find that people's ADHD traits may actually increase because there's the need to mask actually decreases. The need to have a front part that is always on, like, begins to soften. Yeah. The other curious thing about ADHD is, and this is if you ascribe to the dopamine deficit theory of ADHD, is that in order to get dopamine, we need to burn adrenaline. In order to get ADHD, we need to burn adrenaline. Sorry, in order to get dopamine, we need to burn some adrenaline. Yeah. And so that's why ADHD nervous systems like to go, 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 because now I'm burning, as I'm burning, as what looks like getting adrenaline, yeah, I'm actually using up some of my adrenaline stores to get dopamine. It becomes made into dopamine, which is why the nervous system for ADHD can tend to be like this. And as I start to learn to get dopamine in healthier ways, in affirming ways, perhaps there's some oxytocin in there as well. Perhaps my ADHD trauma symptoms reduce and my ADHD traits are there. I'm actually then burning less adrenaline in order to get my dopamine. Yeah.